Hello and welcome to the Radiology Crash Course 101. My name is Savraj Kelsey and I'll be running and developing the rest of the course alongside my colleagues and tutors for you. We hope you find this interesting and engaging, and please don't forget to give us some feedback at the end, whilst also subscribing and signing up to the YouTube channel. Why should you do the course? Well, obviously number one, to gain some additional knowledge and skills to approaching and reading basic radiological scans. We'll hopefully give you a toolkit to improve your confidence as a foundation trainee, as a foundation doctor, especially when you're out on call and you're on your own and you are faced with a chest x-ray or any other modality of scanning and are required to proceed with management. Obviously, don't act on these all on your own. If you feel like you are out of your depth, then please do seek senior support and senior help to make sure you're optimizing patient safety. But as a whole, we'll go through some common presentations, what pathologies will look like on plain films and CTs where we can get a hold of some, and talk you through some interesting case reports that we may have seen. We'll look at CT heads, chests, abdomen and pelvis, whenever we can find those, and then we look at mainly the plain films, so chest x-rays, abdominal x-rays, upper and lower limbs, spinal imaging if possible too. Sessions will be uploaded on YouTube, and they'll be uploaded ideally every 2 or 3 weeks over the next couple of months. Putting them on YouTube will hopefully allow it to be accessed by an international audience. We've already had interest from students both within the country but abroad from Eastern Europe, and we're hoping to allow it to be accessed multiple times by users to share with colleagues and friends to give as wide an assistance to junior medics as possible. Each session will have a feedback form linked to it at the end. It would be highly appreciated if you could complete this. It shouldn't take more than a couple of minutes, both again by QR code and a link. We'll put the links in the descriptions on the YouTube channel under each video, and it will help the tutor with future sessions that they might be running, but also the course as a whole. The YouTube link itself is on here, Radiology Crash Course 101, and the QR code should take you there for you to subscribe and get alerted when new videos are released. Each session will be around 20 minutes, some slightly shorter, some slightly longer. Each session will be focusing in on a specific modality in different areas of the body. So we might run one session on abdominal x-rays, but equally that session might entail some CT abdomen and pelvis, or we might do 2 separate sessions, one on focusing on abdominal x-rays and then the second on CT where we can find relevant imaging. These sessions are out to provide a toolkit for you through a brief overview and a structured approach in reading those modalities of scans, and we'll run through a number of examples and interesting case reports to try and solidify this learning for you. Each session is run by post-F2 doctors who will hopefully have developed an adequate skill set to give you their hints and tips and things that work well for them when they're approaching radiology in their everyday practice. Again, contact is always available from our end through radiologycrashcourse101@gmail.com, as shown here on screen. And if you have any questions specifically for the radiological scans on the course, we'll try and answer them as best we can, but again, we can always refer to our radiology seniors and consultants where needed. So I think it's time to give you a little taste of what you can come to expect with our course, and I'm going to run through 3 key principles within chest x-rays and sort of, I guess, orthopedic scans as well. So number 1 is to get more than one view. The fancy term for this is orthogonal. It basically means to get one image and then another image at 90 degrees to that image. The importance of this is that trauma, especially in trauma, injuries are often missed, and scaphoid fractures, for example, It's common practice now, it's just routine to get more than 2 views, just so we don't miss any subtle pathologies and fractures there. So here's an example of an orthogonal view, and in this example you can see how on the left side here the prosthesis looks like it's in position. However, on the right side you can see just how off the axis it actually is. So a key difference between one view and the next can be seen. The second key thing is to have a systematic approach to reading scans. ABCDE is something that we use in medicine for managing acutely unwell patients, and you can apply the same principles to chest x-rays. You start with the airways from the top down, you look at the trachea, make sure it's midline, make sure the bronchioles are all where you expect them to be. And a lot of this will come with experience. You read more and more scans and you'll get more and more used to what you're looking for, what's normal, what's abnormal. You want to count how many ribs you can see. If there's 10 ribs, it's adequately expanded. Look at the lung markings, make sure they are going to the edges. If they're not, there's a pneumothorax, a small one that you can see in the apices, for example. Look at the angles, look for costophrenic blunting, for any sort of pulmonary effusions. You look at the heart for circulation mainly, so you look at the size, the position. You need to see what the shape is like, if it's any globular heart, for example. And then you look at hilar and pulmonary vessels as well, make sure they're looking like they're patent and in the right place. You then go on to look at the disability side of things, which is fractures of any ribs, shoulder and vertebral body dislocations, and finally you finish off with looking at any free air under the diaphragm. A very important finding, because that is diagnostic for perforations of the bowel, but also in trauma you get subcutaneous emphysema. Again, you'll see those on a chest x-ray plain film. Check the gastric bubble is in the right place, and also look for any hiatus hernia, and then look for any peripheries just so that they're not distracting you. Things like ECG leads, clips from previous surgeries, any NG tubes that might have been put down the patient whilst they've been inpatient, or sometimes even outpatients have NG tubes. And then a more slightly different ABCD approach all the way to I. So this is looking at A being airways, B for bones and soft tissues, again surgical emphysema in there. Look at the cardiac signs and the shape on the x-ray. You look at the diaphragm for any flattening. You look at the effusions on the sides of the angles, the costophrenic angles. The fields, again, make sure they're adequately expanded. You look for any fluid in the fissures, horizontal, oblique, and transverse, and then you look for any foreign bodies. You make sure the great vessels are visualized and the gastric bubbles in the right place, and look at the hilar on left and right, and the mediastinum in its shape and size, sometimes position. And overall, you need to provide an impression of what you think is going on. This is always useful, not only for the people reading the scans and your report of it, but also for you to improve your clinical acumen, for you to make sure that let's say you read something, you think, this is the diagnosis, this is a consolidation on the left side, and then a senior looks at it, or a radiologist looks at it and says, this is more in keeping with, let's say, fibrosis, or it's more in keeping with a lung cancer lesion, then that will ideally change your practice, and you see more scans and identify what looks like a cancer versus what looks like a consolidation from an infective process. So we've covered so far the orthogonal views and the system. The third thing, always make sure you compare with previous imaging. It may have been the case that this patient is presenting with a certain set of symptoms, but the imaging hasn't changed that much from the previous, if at all, and therefore you need to look for other causes of what could have instigated their symptoms. So thank you very much. We'll wrap up there. It's just a brief session giving you an introduction of what we are hoping to cover during this course, how we're going to run it, where you can access all the material. This is an example of what you'd find for feedback forms, a QR code alongside a link. And we hope it's been helpful. And if you have any questions, again, email in through that email address provided. and we hope to see you in our future sessions.